From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. I'm your host, Dr. Preeti Malani, JAMA Deputy Editor. I'm joined by Dr. Jason Zucker, who is an assistant professor of medicine in the Division of Infectious Diseases at Columbia University Irving Medical Center and assistant medical director of the New York City STI Prevention Training Center. Dr. Zucker, along with co-authors Drs. Tatanji and Hazra, published a JAMA Clinical Review article titled Mpox, Clinical Presentation, Diagnostic Approaches, and Treatment Strategies. Jason, welcome.
Thank you so much for having me today.
Beyond infectious disease circles, we didn't hear a lot about Mpox prior to 2022. In fact, Mpox cases outside of Africa were rare and typically linked to international travel or the importation of infected animals. However, today we are seeing cases all over the world with an ongoing public health emergency of international concern in Central Africa due to an increase in infections with clade 1 monkeypox virus. I thought we might start our conversation with a brief summary of the history of Mpox infections and the epidemiology of infections.
Sure. So there's really two things to think about here. The first is that traditionally, Mpox has really been contained to Western and Central Africa. We've had scattered outbreaks in the past, but none anywhere near the size and scope of what was seen in 2022. In 2022, we saw a global outbreak that caused the first public health emergency of international concern around Mpox, which really peaked in the summer of 2022 and then decreased dramatically. And what we're seeing now is a second public health emergency of international concern for clade 1 Mpox in Central Africa. It's really important to know, though, that Mpox never disappeared. While in the summer of 2022, we saw cases peaking at almost 650 per day and quickly dropping, we still see cases in the United States every single day, about 7 per day or around 200 per month, really suggesting that Mpox is likely here to stay and underscoring the importance of ongoing awareness of this disease.
When I think about the state of Mpox infections right now, I find it personally helpful to separate what's happening around the world, as you noted, in Central Africa, and then what's happening in the U.S. What's the current state of infections?
So in the United States, we're having about 200 cases per month, and these are entirely of clade 2B, the same strain we saw during the 2022 outbreak. Globally, the situation is much more complicated. It was just on August 14th that the WHO declared the second public health emergency of international concern, really in response to a surge of infections of clade 1 virus in Central Africa. Complicating matters, you started to see a divergence of clade 1A and 1B, with 1B being identified in the Democratic Republic of the Congo and spreading quickly to neighboring countries like Burundi, Kenya, Rwanda, and Uganda. This strain actually had significant mutations that signified increased human-to-human transmission, very similar to what we saw in 2022 in clade 2 virus. So really demonstrating human-to-human transmission was both possible and probably the predominant mode of spread. And unlike in the US, where cases really have stabilized, the outbreak in Africa continues to grow, with almost 500 new cases per day in the most recent reports.
Clinical manifestations of Mpox infection can vary from mild to severe and can present differently depending on a patient's underlying health conditions and also the type of virus that we're dealing with. What are some of the common signs and symptoms of Mpox?
This is such a great question, and it's such a hard question. It kind of reminds me of what we think about with syphilis, where it can look like a lot of different things, and we really need a high index of suspicion to make sure we don't miss it. The classic presentation, what we saw traditionally with clade 1, was it starting with a viral prodrome, fevers, chills, lymphadenopathy, and other viral symptoms, similar to other viral illnesses. Following the prodrome, patients would develop a rash with these firm, deep-seated, well-defined lesions that would become umbilicated, which is kind of classic for this disease. The rash would start a few days, usually by day 5 after the prodrome, but more commonly a little bit earlier than that, and would start on the face and spread to the extremities, including the palms and soles. It traditionally would go through synchronized stages, so all of the lesions would sort of progress in a synchronized manner, from papules to vesicles to pustules to umbilicated pustules. The lesions would be extremely painful, lasting up to 4 weeks. We also tend to think of clade 1 as having more lesions, which remains true, and a higher mortality than clade 2 virus. With clade 2, what we saw was a little bit different. and that may have been due to mode of transmission. Frequently, rash would occur before the prodrome, or the prodrome wouldn't occur at all. Another key feature of clade 2 was that we saw the rash would appear with multiple lesions in different stages on the same area of the body. So on the arm, people could have multiple lesions in different stages at the same time. We also saw a much higher frequency of genital and anal lesions, including lesions causing proctitis, which again may be related to the mode of transmission of clade 2 virus. This is really for immunocompetent people. As you said at the beginning, we do see different disease patterns in individuals who are immunocompromised, particularly those with advanced HIV. In those patients, we'd see things like severe necrotizing skin lesions that just continue to progress, and disseminated viremia that can affect multiple organ systems, most commonly the lungs and GI tract.
Let's move on to diagnosis and beyond having a high index of suspicion. If I'm in clinic today and I'm concerned that a patient might have Mpox infection, how do I approach making that diagnosis?
So thinking about the diagnosis is a great first step. We need to make sure it's on our differential diagnosis, and we're seeing people every day who are coming to our clinic who had been seen in other places where they were not thinking about Mpox because it's not at the forefront of people's minds. Once you suspect the diagnosis, we make it using DNA amplification techniques, or PCR. Providers should wear appropriate personal protective equipment. This includes gown, gloves, eye protection, and N95 respirator. It's important to remember that we should be collecting 2 swabs from 2 separate skin lesions. Vigorous swabbing over the top of the lesion is all you need to do to collect enough viral DNA for testing. We really should try to avoid unroofing or aspirating lesions to avoid the risk of exposure to the healthcare worker, as many cases of nosocomial transmission have actually occurred from healthcare worker needle sticks. We can then send that sample to either your local lab or a reference lab for testing. And if your patient has traveled to Central Africa or had contact with individuals from that region, we really should be looking for clade-specific testing, not just orthopoxvirus testing.
One of the things that's been helpful is that testing is much more available now than in 2022. But as you note, it can vary from place to place. So it's important for clinicians to have a plan and maybe make some phone calls to the local public health department or lab.
That's a great point. It's much more available than before. It's not just public health labs, but the commercial labs are all able to run Mpox as well. And actually, one of the commercial labs recently got a home specimen collection approved. And so you have the ability to collect specimens at home and send them in for testing, which could be really helpful for patients who are hesitant to come to clinic for stigma and other reasons.
Let's talk about treatment. There are several different therapeutics that get mentioned. Many of these are being tested in clinical trials. Are there antivirals or other therapies that can effectively treat Mpox?
It's important to remember that there's no FDA-approved treatment specifically for Mpox. Several antiviral medications that we think about for other diseases that are approved for smallpox or CMV retinitis are used, but without good clinical trial data. Most importantly are supportive care measures that are available for everyone. Most people with Mpox experience a self-limiting illness that will recover in less than 4 weeks, and they don't need antiviral therapy. The focus of supportive care is really aimed at relieving symptoms, promoting healing, preventing secondary bacterial infection, and treating secondary bacterial infection when it occurs. And with good supportive care, we can really reduce the morbidity of this disease. On the other hand, there are patients who have severe cases, particularly those who are immunocompromised, who really do need some sort of antiviral or other medical countermeasure to help. During this outbreak, the most commonly used antiviral was tecovirimat, or TPOXX. Over 7,000 people received this medication during the course of this outbreak. What we can say so far is that the medication does appear safe, but we don't have a lot of great data on its efficacy. The POM-007 study, which was completed in the Democratic Republic of the Congo, released top-line results, which did not show a benefit of tecovirimat. That study involved persons with clade 1 virus and also enrolled a high number of children who likely had a different mode of transmission than what we've seen in clade 2. So the STOMP trial and the UNITY trial are the 2 largest studies still enrolling, STOMP in the United States and UNITY in South America, hoping to answer the questions about whether tecovirimat works for clade 2B. Less commonly used due to side effect reasons include cidofovir and brincidofovir, both of which have in vitro data on the possibility of effectiveness, particularly for patients with severe complicated Mpox. Cidofovir has been used off-label, but there's really limited data from human trials. And its drawback is nephrotoxicity, which many of us know is a reason we don't use it very frequently. Brincidofovir is a prodrug of cidofovir that's considered to be less harmful for the kidneys. It's been used under an FDA expanded access program similar to tecovirimat, And its primary side effects are liver enzyme elevations and GI side effects. But the truth is we have no in vivo data on the effectiveness of brimcidofovir for treating Mpox in humans. The last thing that is available for people is Vaccinia immunoglobulin, so antibodies against Vaccinia virus. It has been considered for individuals who are immunocompromised. You wouldn't expect to mount an immune response. But again, there's no published data on VIGIV's effectiveness for Mpox. One other thing I'll add is that in addition to VIGIV, there are monoclonal antibodies that are in the works that we expect in the near future will make it into hopefully clinical trials as well. I think what we're really saying is we don't know, other than supportive care, what works for Mpox. And what we really need are randomized controlled trials to properly evaluate these medications, both for effectiveness and safety, to guide the future of this disease, because it's not going away anytime soon.
Yeah, and I just want to underscore the symptom management, because pain is something that we've certainly seen as being so prominent. And while we sort out what antivirals, if any, have effectiveness, it's important to really help people's comfort.
Absolutely. And not just that, but when you look at supportive care has major benefits. One of the things that PALM 007 looked at was actually optimal supportive care. We at some point thought that the mortality of clade 1 virus would be 5 to 10%. And we saw in PALM that in the control arm, where they received optimal supportive care but no antivirals, that mortality dropped to 1.7%. And so with optimal supportive care, we can really make a difference for our patients, pain control, comfort, and mortality benefits, all with optimal supportive care.
Let's move from treatment to prevention. And there are several approaches to prevention that are described in your review. Behavioral change, vaccination, which we have talked a lot about in the last couple of years, as well as pre- and post-exposure prophylaxis. Can you walk us through these different approaches?
Absolutely. So we'll start with behavioral change. During the 2022 outbreak, vulnerable groups, especially gay, bisexual, and other men who have sex with men, really took proactive steps to reduce their likelihood of infection. There's lots of data that both in the US and the UK, they reduced the number of sexual partners, they limited sexual encounters, and that these self-protective behaviors actually played a huge role in slowing the spread of the virus. However, at the same time, we want to be sex positive and we want our patients to have whatever sex lives they desire. And so behavioral change is really not the end goal, but can certainly serve as a bridge to things like vaccines. It's really more of a temporary solution than a permanent one. The bridge is vaccines, which can be used for both post-exposure prophylaxis and pre-exposure prophylaxis. The CDC does recommend vaccination with an Mpox vaccine for individuals with known or suspected exposure to Mpox within 4 days, but up to 14 days after exposure. However, our data on effectiveness is extremely limited. We really just have animal studies. I think we have a lot more data on vaccination for pre-exposure prophylaxis. Currently, there are 2 vaccines that are licensed for Mpox prevention, ACAM2000 and JYNNEOS. I'm not really going to talk about ACAM2000 because it hasn't been used during this outbreak. We've used almost exclusively the modified Vaccinia and Ankara or JYNNEOS vaccine. It's a 1-dose vaccine and has milder side effects, which is I think why it's preferred. And the ACIP recommends it for people vulnerable to Mpox. I want to be clear, vaccination does not completely prevent Mpox. Infections tend to be milder and are less likely to lead to hospitalization or death. And studies show that the 2-dose vaccine has an efficacy rate of preventing Mpox between 66 and 86%. So when we see breakthrough infections, it's not surprising, but we expect that those infections are going to be more mild and lead to less hospitalization and death. Just like with treatment, there still is a lot we need to know, particularly among the long-term protection and duration of immunity, which is really still under investigation. We had access to vaccines in the United States. Originally, they were limited, and then over time, we gained more and more access. The reason we're seeing such a large outbreak globally now is that vaccination was not available throughout the world. The emergence of viral strains like the clade 1b that came out of the Democratic Republic of Congo really highlights the need for global surveillance and global equity to vaccination to help control the virus, not just in this country, but abroad as well, because we know whatever happens abroad will come here eventually. I will say the WHO has recently pre-qualified the JYNNEOS vaccine, which is one big step in improving access in these regions.
Thank you for raising these important health equity issues. This is just one of the latest examples of the access issues and, as you mentioned, vaccine equity, as well as just having trial data to guide something that is devastating large communities all over the world. Any final thoughts that you want to share with our listeners?
Sure. The first is that don't forget that Mpox remains a concern both here and abroad. Just because we're hearing about high numbers of cases internationally doesn't mean we're still not seeing ongoing transmission within the US. The second thing is don't forget your differential diagnosis. Mpox can resemble a lot of conditions like secondary syphilis, herpes, zoster, and other infections. And it's also very common for patients with Mpox to have co-occurring sexually transmitted infections. So comprehensive STI screening, comprehensive HIV and STI prevention services are important. The disease's severity can vary widely. It's easy to think that it's a self-limited illness, which it is in most people. But for those who are immunocompromised, they can have life-threatening complications. And supportive care remains essential, but so do conducting clinical trials to ensure that we have adequate antivirals for those with more severe disease. Vaccination is and remains our critical prevention tool. It prevents disease in some patients and reduces severity in others, and it's vital for controlling the global outbreak. We need to conduct studies and we need more funding and support for research. We need comprehensive epidemiological research to better understand the evolving transmission patterns and development of new clades, clinical studies to determine the optimal use of supportive care and assess the efficacy of antiviral treatments, vaccination studies to understand the duration of vaccination, immunologic studies to understand the different immune responses, particularly among those who are immunocompromised, vaccine research to determine the long-term effectiveness of current vaccines and the potential need for future boosters.
Jason, thank you for joining me. I'm Dr. Preeti Malani. I've been speaking with Dr. Jason Zucker about Mpox infections. You can find a link to the article in this episode's description. This episode was produced by Daniel Masusi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.